Septic shock, ICU management from presentation to discharge. Sepsis kills over 270,000 Americans every year. It is the leading cause of death in ICUs worldwide. And yet, with rapid recognition and protocolized management, outcomes improve dramatically. Today we walk through septic shock, from the pathophysiology to the Hour 1 bundle, to vasopressors, antibiotics, and the evidence that drives every decision. Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is a subset of sepsis in which circulatory, cellular, and metabolic abnormalities are so severe that mortality is substantially increased. Clinically, septic shock is identified by the need for vasopressors to maintain a mean arterial pressure of 65 mm mercury or greater and a serum lactate above 2 millimole per liter despite adequate fluid resuscitation. The pathophysiology begins with a pathogen, bacterial, viral, fungal, or parasitic, triggering an overwhelming immune response. Pattern recognition receptors, like toll-like receptors, detect pathogen-associated molecular patterns, PAMPs, and release a storm of inflammatory cytokines. TNF-alpha, IL-1, IL-6. This cytokine storm causes widespread endothelial damage, leading to increased vascular permeability, vasodilation, and distributive shock. Blood is maldistributed. Tissues are not perfused, despite normal or elevated cardiac output. Mitochondrial dysfunction impairs oxygen utilization at the cellular level. This is cytopathic hypoxia. Lactate rises not only from anaerobic metabolism, but from impaired clearance and beta-adrenergic stimulation. Recognition is everything. Use the qSOFA score at the bedside. Altered mental status, respiratory rate above 22, systolic BP below 100. 2 or more points suggest sepsis. Confirm with the full SOFA score assessing 6 organ systems: respiratory, coagulation, liver, cardiovascular, CNS, and renal. A SOFA score of 2 or more above baseline indicates organ dysfunction. The Surviving Sepsis Campaign Hour 1 bundle is the framework for immediate management. Within 1 hour, measure lactate. If above 2, remeasure after resuscitation. Obtain blood cultures, 2 sets, before antibiotics. Start broad-spectrum IV antibiotics. Begin IV crystalloid resuscitation, 30 milliliters per kilogram of body weight for hypotension or lactate above 4. Apply vasopressors for MAP below 65 despite fluids.
Antibiotic selection in septic shock should be broad, early, and de-escalated once cultures return. For community-acquired sepsis, cover gram-positives and gram-negatives, typically piperacillin and tazobactam or a carbapenem plus vancomycin for MRSA coverage if risk factors are present. For healthcare-associated or ICU-acquired sepsis, broaden to cover Pseudomonas and resistant organisms. For abdominal source, ensure anaerobic coverage. For meningitis, add dexamethasone and use ceftriaxone with vancomycin. Timing matters. Every hour of delay in antibiotics increases mortality by approximately 7%. Draw cultures first, but do not let culture collection delay antibiotics beyond 45 minutes. Vasopressors are the cornerstone of hemodynamic management. Norepinephrine is the first-line vasopressor. It increases SVR via alpha-1 agonism with modest beta-1 effects, raising MAP without dramatically increasing heart rate. Target MAP of 65 mm mercury, higher targets of 80-85 showed no benefit in the sepsis PAM trial, except in patients with chronic hypertension. Add vasopressin at 0.03 units per minute as a second agent to spare norepinephrine dose. Epinephrine is third line. Dopamine is no longer preferred, it causes more arrhythmias. Phenylephrine is pure alpha-1, avoid in low cardiac output states. Fluid resuscitation, the 30 milliliters per kilogram bolus is the starting point, but ongoing fluid therapy should be guided by dynamic assessments of fluid responsiveness, pulse pressure variation, passive leg raise, or point-of-care ultrasound assessing IVC collapsibility. Over-resuscitation causes abdominal compartment syndrome, pulmonary edema, and worse outcomes. The SMART trial showed balanced crystalloids, lactated ringers, or plasmalyte are superior to normal saline in reducing acute kidney injury and death. Corticosteroids, hydrocortisone 200 mg per day by continuous infusion is recommended for refractory septic shock. Vasopressors not weaning despite adequate resuscitation. The adrenal and APRO-CCS trials support benefit in shock reversal, though mortality benefit remains debated. Source control is critical. Drain abscesses, remove infected catheters, debride infected tissue. Serial lactate clearance guides resuscitation adequacy. Target greater than 10% clearance every 2 hours. Glucose should be maintained between 140 and 180 milligrams per deciliter. DVT prophylaxis, stress ulcer prophylaxis, and lung protective ventilation complete the bundle. Septic shock is survivable. Recognition, speed, and protocolized care save lives. Subscribe to Medical Sciences Unfolded for daily clinical deep dives.